You've just had a lecture about the neural feedbacks of blood pressure control, and we've talked a lot about hypertension, so we're going to talk about the opposite end of the spectrum. Today's talk is going to deal with shock and hypotension. Hypotension can be defined as a lower than expected blood pressure for an individual. Normally, we think of this as a blood pressure less than 90 systolic or a mean arterial pressure of less than 65. However, shock is a clinical term in addition to the numerical values. Shock is an inadequate perfusion to meet the metabolic needs of the tissue or organ. It's simple economics of supply versus demand. Tissues need the oxygen and nutrients that are being pumped around the vasculature via the heart. You may have heard about screening tools to rapidly identify patients in shock or predict their in-hospital mortality rate, but one of the most common presentations is going to be a low mean arterial pressure. When tissues are inadequately perfused, they can no longer carry out their innate functioning. For instance, if the brain receives inadequate perfusion, even momentarily, it can alter the patient's level of consciousness. If we are unable to perfuse the kidneys, then we can elicit renal dysfunction. If we were going to assess shock in a clinical scenario, we need to assess a few things. The tank. This is going to be the volume within the system. The tone or the pipes, which are the vasculature, and the pump. This is the heart and its squeeze. We won't discuss the workup of a patient in shock, but we can discuss the categories of shock and what it looks like in terms of the tank, the pipe, and the pump. Let's start with cardiogenic shock. A common scenario is a patient who presents with a massive myocardial infarction of the LAD. Cardiogenic shock is primarily a pump problem. Here we have the inability to generate an adequate cardiac output. The main problem here is the contractility or stroke volume. Let's say that the patient comes into clinic short of breath with a blood pressure of 80/60 and a heart rate of 105, respiratory rate of 30, and an oxygen saturation of 90%. The heart rate is not the main problem. That's the reflex. When the pump fails, fluid backs up. Left-sided failure to pump backs up the fluid into the lungs, resulting in pulmonary edema. Right-sided failure backs up fluid in the venous system. When we took this person's blood pressure, we saw that there was a low pulse pressure. And if we did a bedside echocardiogram, we may even see that they have a reduced ejection fraction. We remember that pulse pressure is the systolic minus the diastolic, and the ejection fraction is the end diastolic volume minus the end systolic volume over the end diastolic volume. Treatment here, as with all patients, is to attempt and correct the underlying cause. Improve oxygenation if hypoxemic and stabilize the cardiac profile needed to perfuse critical tissues. A condition that is usually coupled with cardiogenic shock is obstructive shock. Here, in obstructive shock, there is a physical barrier to producing an output. This may be in the form of a large pulmonary embolism where the blood is blocked from going from the right side of the heart through the lungs, or in the instance of a cardiac tamponade, where there is external pressure applied, preventing proper filling of the ventricle, which prevents a proper cardiac output. Treatment in obstructive shock is to correct the underlying pathology. We'll revisit this form of shock in the pulmonary section too when we talk about tension pneumothoraxes. Next, let's take hypovolemic shock. This is primarily a tank problem. We lose the preload and therefore cannot generate an adequate cardiac output. Again, the response of the body to a drop in pressure is to clamp down on the vasculature and increase the heart rate. This reflex response is to increase the arterial pressure. Based on the type of fluid loss and the amount dictates the type of resuscitation that is needed. If we lose water and electrolytes after a severe diarrhea episode, then it would make sense that the resuscitation fluid would either be normal saline or lactated ringers. But if we are in hypovolemic shock after a significant bleeding event, then the resuscitation may need to be in the form of blood products. The next category is distributive shock. This type of shock is a vascular disruption and can be broken down into subcategories: anaphylaxis, sepsis, or neurogenic shock. This group is mostly a problem with the vessel tone. Let's start with anaphylaxis. The kid with the peanut allergy that bites into the PB&J on accident. The child breaks out in hives, throat and tongue start swelling, and has a tank in their blood pressure. This is the classic type 1 hypersensitivity response where an antigen cross-links the preformed IgE on pre-sensitized mast cells. The mast cells degranulate and release histamine. Histamine is a vasodilator. Treatment, as you all are familiar with, is epinephrine. You usually see this in the form of an EpiPen given as an intramuscular injection. Epinephrine serves as a vasopressor to fix the vasodilation problem. The alpha-1 receptors are what is important here. But epinephrine also can stabilize the mast cells, preventing further degranulation with its beta-2 properties. Epinephrine's beta-2 activity also dilates the airways. We have additional actions of epinephrine in increasing the contractility of the myocardium and increasing the rate, which is chronotropy, via the beta-1 receptor. You may be familiar with treatments for allergic reactions like antihistamine or steroids, but in anaphylaxis, the key treatment is early epinephrine. Sepsis is an inflammatory response to an infection. This dysregulated host response mediated by cytokines causes a whole list of responses, but mainly vascular leakiness. We get a loss of intravascular volume and a third spacing of fluid. Third spacing meaning fluid where it's not supposed to be. Additionally, the myocardium could lose contractility, producing a low output, or the vasculature could collapse in response to circulating toxins. Treatment here is aimed at eliminating the pathogen and circulating the cardiovascular system. An echocardiogram of the heart may not help you in determining that this patient has septic shock, but it can help you guide your treatment. If your assessment revealed an inadequately contracting myocardium, then you may need an inotropic agent. However, if you saw a vastly dilated vascular system, then you may need a vasopressor and fluids, or a combination of the two. In neurogenic shock, or following a spinal cord injury, we see not only that the motor pathways are disrupted, but the sympathetic control of the vascular tone is blocked. As we remember from the first lecture, our body needs to control the vascular tone because without it, there would be complete circulatory collapse. In order to support this patient's hemodynamics, we will need to return some sympathetic tone to the vasculature by giving a vasopressor. When you're working through problems with shock and hypotension, try and think about the different categories. What's happening in the pump, what's happening in the tank, and what's happening in the pipes. Which one or which combination does the patient need support in to improve their hemodynamics? Thank you for watching, and good luck with your studies.